Welcome to the Funnel Effect. We are diving deep today into, well, one of the most intense high-stakes frontiers in modern interventional cardiology. We're looking at how we use advanced mechanical devices to stabilize the very sickest patients during these incredibly delicate, often life-saving heart procedures.
It really is. It's a field just defined by rapid technological change, but also critical uncertainty. So today we're doing an integrated analysis of mechanical circulatory support, or MCS devices, specifically looking at their use during complex, high-risk percutaneous coronary intervention, which most people know as PCI.
Right, CHIP, PCI.
Yeah.
And our entire analysis today is drawn from a really exhaustive and very current review. It's published in Eurointervention just recently, 2025, Volume 21, pages E149 through E160. The paper itself is titled Mechanical Circulatory Support for Complex High-Risk Percutaneous Coronary Intervention. And we're pulling our insights directly from the corresponding author, Robert W. Yeh, and his esteemed colleagues, Enrico G. Ferro, Joseph M. Kim, Christina Lawani, and Don J. Abbott.
And our mission today, for you, the learner, is really to try and cut through some of the confusion. There's this evidence lag we often talk about. We're synthesizing both the, frankly, limited data from randomized trials and, crucially, this huge body of real-world data, or RWD, to understand the current clinical thinking. We want to figure out, who really benefits the most when we deploy these powerful, but let's face it, inherently risky support systems during these really challenging heart procedures.
Okay, let's unpack this a bit and set the stage. Because the kinds of patients needing revascularization, their demographics have changed dramatically, haven't they?
Oh, absolutely. It's pivotal, thanks to, decades of improvement in preventing and initially treating coronary artery disease. CAP patients are just surviving longer, which means they generally present much later in life.
So they survived that first heart attack maybe 15 years ago, but now they're back, and the problem is much, much harder to fix.
Exactly. And when they do present for an intervention, they are often older, frailer, and critically, they carry a far heavier burden of disease. We're talking more anatomically complex coronary disease and just a longer list of other medical problems, comorbidities.
Right. And this shift, this increasing complexity and patient risk profile, it's basically spurred this entire clinical niche we now call complex high-risk PCI, or CHE.
That's it. And these interventions, they're a world away from routine stenting. They demand specialized tools, specialized skills, and often they really require that temporary assistance from MCS devices just to get the job done safely.
Which brings us right to the core challenge in the field, doesn't it? The definition. As the sources point out, there just isn't a universal, agreed-upon definition for complex, high-risk PCI.
Yeah, the authors really emphasize this. Complex and high-risk are complementary, definitely, but they are distinct concepts. They're not always interchangeable. You could have a patient with incredibly complex anatomy, but who's otherwise pretty healthy.
Yeah.
Or you could have someone with relatively simple blockages, anatomically speaking, but they're so medically unstable that they're considered extremely high risk. We have to separate the plumbing from the engine, so to speak.
That's a good analogy.
Yeah.
Let's start with the plumbing then. Defining complex. What specific coronary anatomy, what lesion characteristics immediately flag a case as, okay, this might need special tools, maybe even MCS?
Right. So complexity refers strictly to the sort of geography and the nature of the blockage itself. We're talking severe extensive disease. The classic examples would be 3-vessel disease, 3VD, where all 3 major coronary arteries have significant blockages.
Right.
Or intervening on the unprotected left main coronary artery, that's the main trunk supplying the whole left side of the heart.
And going after the unprotected left main, that's always felt like, well, a massive risk if something goes wrong there.
It's potentially catastrophic, yes. Or the equivalent scenario, working on the last patent conduit,
Right.
the only vessel that's keeping the patient perfused. Beyond those major arteries, complexity also includes the nature of the blockage itself. Things like chronic total occlusions, CTOs.
Ah, yes, the CTOs. Arteries blocked solid for months.
Exactly, usually defined as more than 3 months. These often require hours, literally hours, of specialized wires and techniques just to get through.
And what about the physical characteristics? Not just where it is, but what it's like.
Yeah, that's crucial too. We include detailed procedures on bifurcation or trifurcation lesions where the artery splits, needing really precise stenting, often multiple stents. And critically important these days, arteries that are choked by severe calcification or just diffuse disease spread out along the vessel.
Like concrete in the artery wall.
Pretty much. When it's like that, simply inflating a balloon isn't going to cut it. It won't expand.
And that anatomical complexity, the calcification, it forces the use of more specialized tools, right? Which adds its own layer of risk and stress.
Absolutely. When a case moves from routine to complex, the operator has to reach for advanced tools, things like atherectomy devices.
The rotablator orbital atherectomy.
Exactly, those high-speed rotational burrs designed to basically shave or drill out that hard calcium and plaque. Or intravascular lithotripsy, IVL, which uses sonic shock waves like cracking kidney stones, but inside the artery to break up dense calcium so the vessel can then be expanded.
And the mechanical stress from using those tools, it's not trivial.
Not at all. It significantly increases the risk of procedural injury, dissection, perforation, or even acute vessel closure.
Okay, so that's complex. Now let's switch to the other term, high risk. This focuses more on the engine, right? The patient's overall health. What are the key pre-procedural characteristics that define a patient as high risk, even if their blockage isn't anatomically super complex?
Right. High risk centers on those comorbidities that limit the patient's physiological reserve. Their ability to withstand the stress of the procedure, probably the biggest single measurable red flag is reduced left ventricular ejection fraction, or LVEF.
So the main pumping chamber of the heart is already weak.
Exactly. If the LVEF is already low, say under 30% or 35%, the heart is basically operating on fumes. Any drop in blood pressure during the procedure, even a temporary one, could be devastating.
They just have no reserve.
Minimal reserve, correct. And this is often compounded by other existing conditions, things like significant valvular heart disease, severe peripheral artery disease, or carotid disease, or serious organ dysfunction problems with the lungs, kidneys, or liver. We also have to account for recent or currently decompensated heart failure. And we often use surgical risk models, like the STS score, even though it's a PCI, to get a sense of overall risk.
The source material also brings up something critical, but maybe harder to quantify: frailty.
Yes, clinical frailty is hugely important, though it often remains a bit subjective compared to, say, an LVEF number. It really speaks to the patient's overall biological age, their resilience, their physiological ability to withstand a major trauma, which a 3-hour complex PCI under anesthesia certainly can be.
It's already being used in TVI risk scores, right?
Yeah. It is, yeah. It's pretty well incorporated into risk calculators for transcatheter aortic valve implantation, or TVI, but its formal adoption for high-risk PCI risk stratification has been a bit slower.
But it makes intuitive sense. If a patient is frail, every potential complication, bleeding, kidney injury, a longer recovery time, it's just amplified exponentially.
It's arguably the ultimate unmeasured risk factor sometimes. And then finally, we have the acuity of presentation. How sick are they right now? The risk spectrum here runs all the way from a stable, elective, outpatient procedure to somebody coming in with an acute coronary syndrome NSTEMI or STEMI, and potentially complicated by the patient crashing into cardiogenic shock or even having an outright cardiac arrest before or during the procedure. These acute situations radically change the hemodynamics and the urgency for support.
Wow. Okay, so integrating all these different pieces, the complex anatomy, the patient's underlying risk, their real-time hemodynamic status, it sounds like a massive cognitive task. Probably too much for one person alone in the moment.
That's absolutely the consensus now. It really demands multidisciplinary expertise, which is why the major international guidelines, both European and American, give a Class I recommendation that's the highest level of evidence for using a structured heart team approach.
So getting the interventionalists, the cardiac surgeons, the non-interventional cardiologists, maybe even heart failure specialists, all together.
Exactly. All discussing the risks and benefits for that specific patient to decide the best path forward. Is it surgery? Is it complex PCI? Maybe with support? Or is medical management actually the safest option?
So given all that complexity and risk, why do we need mechanical circulatory support in the first place? If the heart team decides PCI is the way to go, why can't standard drugs and just really good technique be enough?
Well, because the hard reality is that the inherent mortality for these combined complex and high-risk interventions, it's still highly variable and often disturbingly high. The range is anywhere from maybe 2% up to 20% in some series. The fundamental hypothesis driving the adoption of MCS is that it provides immediate, robust, non-pharmacologic hemodynamic stability.
And how does that stability actually help the person doing the procedure, the interventionalist?
It achieves two major goals at the same time. First, it immediately reduces myocardial oxygen consumption. It actively rests the left ventricle, which is critical if the patient already has a low LVEF, like we discussed.
Okay, it takes the workload off the heart.
Precisely. Second, it improves systemic perfusion. It makes sure vital organs like the brain and the kidneys get enough blood flow, even if the heart rate drops or the blood pressure dips momentarily during a tricky part of the intervention.
So it acts like a safety net. It buys time. It allows the interventional cardiologist to focus on the main goal, which is complete revascularization, right? Fixing all the significant blockages.
Exactly that. Without MCS, an operator might feel forced to bail out of a difficult CTO attempt, or maybe skip fixing a second diseased vessel because the patient's blood pressure is just getting too unstable. With MCS providing that hemodynamic protection, they can pursue a more thorough, more complete revascularization, even if that means doing multiple runs of atherectomy or really taking the time to properly deal with that dense calcified lesion.
And the long-term benefit of getting that complete fix is potentially huge.
It's massive, but achieving it often requires that temporary stability that MCS can provide.
Okay, that's the benefit side laid out clearly.
Yep.
Now let's be just as explicit about the critical trade-off, the risks involved with using these devices.
Yes, the source is very clear on this. Those potential benefits are definitely offset by significant procedural risks inherent to MCS use itself. The two major categories of risk are vascular injury and bleeding, because these devices, especially the higher flow ones, require large bore access through major arteries, like the femoral artery.
We're talking big catheters.
Very big. And they necessitate therapeutic levels of anticoagulation, blood thinners, while they're in place. So the potential for major access site complications, hematomas, pseudoaneurysms, retroperitoneal bleeds, or just catastrophic bleeding is significantly higher.
And figuring out which patient benefits enough to justify taking on that immediate elevated risk, that's the core clinical challenge, isn't it?
That is the million-dollar question every heart team grapples with.
Okay, before we jump into the specifics of the different MCS devices, maybe we should briefly touch on those initial stopgap measures. Vasoactive agents, like pressors, why are they often not ideal for these long, complex procedures?
Right. Vasoactive agents like norepinephrine or dopamine, they're essential for initial support, especially in shock, to keep the blood pressure up acutely. But their mechanism, well, it limits their usefulness for prolonged, complex PCI support. While they do boost blood pressure, they achieve this primarily by increasing the heart's workload.
They basically push the heart harder.
Exactly. They increase cardiac metabolic demands, make the heart consume more oxygen, and they often promote electrical ectopi, things like ventricular tachycardia, irregular heart rhythms.
Not what you want during a delicate procedure.
Definitely not. So this makes them undesirable for the kind of extended support you might need during a procedure lasting 2, 3, maybe even 4 hours. They don't rest the heart, they actually push it closer to the edge, whereas the whole point of modern MCS is to actively unload and support the heart, letting it rest while the work gets done.
Okay, that distinction is clear. Now let's get into the devices themselves, but maybe start with this striking geographical variation the paper highlights. This really seems to underscore that evidence lag theme. If the data were totally clear, you'd expect similar adoption rates everywhere, right? But that's not what we see.
Not at all. The variability is truly remarkable, and it screams uncertainty and lack of consensus. Let's start with the USA. Data from big registries like the NCDR Cath PCI show that operators there account for a really disproportionate share of MCS use globally.
And the key finding in the US isn't just the overall use, but the dramatic shift in which device gets used.
That's right. While overall MCS use in elective PCI only increased somewhat modestly, maybe from about 0.2% back in 2009 up to 0.6% by 2018, the internal makeup changed completely.
The intra-aortic balloon pump, the IABP, used to be the main player.
It was dominant, yes. But following the introduction of the Impella microaxial pump around 2010, its adoption just exploded in the US. By 2018, Impella represented something like 70.5% of all MCS procedures there.
And this really picked up speed after 2015, didn't it, when Impella got its specific FDA approval for high-risk PCI?
It did. The overall MCS use jumped pretty sharply then, up to about 3.5% by 2016. But here's the detail that just screams clinical uncertainty. The source notes a greater than 5-fold variation in the likelihood of Impella use among comparable patients, just depending on which randomly selected U.S. hospital they went to.
Wow, 5-fold. That's huge.
It's deeply problematic. It means two patients, essentially identical in terms of anatomy and LVEF, walk into two different hospitals, and they have radically different chances of getting advanced support.
So it suggests things like hospital protocols, individual doctor preference, maybe even reimbursement policies are often driving the decision more than standardized, evidence-based criteria.
That's certainly what the data implies. Now, let's contrast that really aggressive U.S. adoption with what happened in the U.K.
Right. A totally different story there.
Completely. The UK narrative is one of conservative retreats, almost. According to their national BCIS registry, the use of MCS actually fell steadily over that same period from 2.0% in 2010 down to just 0.9% by 2017.
And that fall was driven by less IABP use.
Entirely driven by a decline in IABP use. And crucially, Impella use in the UK remained consistently very low, just hovering around 0.1%.
So faced with inconclusive early trial data, the U.S. largely embraced the newer, higher flow device, while the U.K. kind of reacted by scaling back the use of the older device and not really adopting the new one. Aggressive adoption versus maybe conservative skepticism.
That's a fair summary. And we see a similar sort of cautious approach in Japan as well. In 2018, their MCS use for high-risk PCI was low, only about 0.6%. And it was overwhelmingly driven by the IABP, making up about 85% of those cases. Use rates for ECMO and Impella were marginal, like 6% and 4% respectively.
But Italy stands out as a European exception.
It does. Their multi-center IMP-IT registry showed quite the opposite trend, an increasing rate of MCS use, growing by a pretty striking 40% per year between 2004 and 2018.
So what does this patchwork quilt of different practices tell us?
Well, this whole mosaic of geographic and temporal variability, it signals a massive evidence gap. If the randomized clinical trial data had provided a clear, strong, positive signal, you'd expect adoption to be more uniform, probably higher overall. Instead, we have the situation where local regulatory hurdles, insurance coverage decisions, and just clinical intuition, which often conflicts between centers, seem to be the primary drivers of who gets these expensive and high-risk interventions.
Okay, that lack of consensus forces us to really strip it back to the basics. Let's compare the currently available MCS platforms based purely on their mechanics, how much support they offer, and crucially, the size of the access they require. Because that sheath size is the direct link to the vascular risk we talked about.
Right, we can sort of organize them by increasing capacity and complexity.
Let's start with the oldest, the lowest flow device, the IABP.
Okay, the intra-aortic balloon pump, it's the veteran here. Lowest flow augmentation device. It relies on a helium-filled balloon positioned in the descending aorta. Its mechanism is pure counterpulsation. It rapidly inflates during diastole when the heart's resting and filling to push blood backwards towards the coronary arteries, boosting their perfusion pressure.
Okay.
Then it rapidly deflates just before systole, right before the heart pumps, which reduces the resistance the heart pumps against, the afterload.
So it's not actively pumping blood itself. It's more like timing a pressure wave to help the heart do its job a bit more efficiently.
Exactly. It provides a pretty modest cardiac output augmentation, maybe around 0.5 liters per minute, LPM. The major advantage of the IABP has always been its relatively small access profile, typically 7 or 8 French, usually inserted via the femoral artery, sometimes the axillary. That size is generally manageable from a vascular standpoint.
Okay. Next up, the device that really changed the landscape, especially in the U.S., the Impella 2.5 and the CP models.
Right. These are transvalvular microaxial flow pumps. The system involves steering a specialized cannula, which contains a tiny motor and propeller across the aortic valve. The inflow section sits in the left ventricle, and the outflow section sits in the ascending aorta just above the valve. It acts like a powerful little submersible pump, actively drawing blood from the LV and expelling it forward into the aorta.
And what does that active pumping achieve that the IABP doesn't?
It achieves significant LV unloading. It actively reduces the ventricle's workload much more than the IABP. This provides much higher cardiac output augmentation. The Impella CP model can provide around 3.0 to 3.5 LPM, sometimes a bit more.
But that superior support comes at the cost of bigger access.
It does. That's the trade-off. They require a much larger sheath, 13 or 14 French, which drastically increases the procedural risk, particularly vascular complications. Access is typically femoral or axillary, or potentially via newer routes like transcaval, which we can discuss later.
Okay. Then there's the tandem heart system, a completely different approach conceptually.
Very different. Tandem heart is essentially a left atrial to femoral artery bypass system. Unlike Impella, it doesn't cross the aortic valve at all. Instead, it requires a technically demanding procedure called a transeptal puncture, actually piercing the wall between the heart's left and right atria to place a large inflow cannula into the left atrium. Blood is drawn out, goes through an external extracorporeal pump, and is then returned retrogradely into the systemic circulation via a separate arterial outflow cannula, usually in the other femoral artery.
That transeptal puncture sounds like a major hurdle. Why is that step so tricky?
It requires specialized training and equipment, usually fluoroscopic and often echoguidus, to safely cross the atrial septum without causing serious complications like tamponade. Impella completely avoids this step, which is certainly a major reason for its higher adoption rate globally.
On the flow support,
Hmm.
access size.
Tandem heart augments flow comparably to the Impella CP, potentially up to 3.5 or even 4 LPM, but it requires two large access sites. A massive 21 French cannula in the femoral vein for the inflow and a 15 to 19 French cannula in the femoral artery for the outflow, so two large holes.
Right. Finally, the highest level of support, VA ECMO. The big guns, as they say.
Exactly. Venoarterial extracorporeal membrane oxygenation provides full combined circulatory and respiratory support. It uses a large venous inflow cannula, usually in the femoral vein or internal jugular, to drain venous blood. This blood passes through an external oxygenator membrane, which adds oxygen and removes CO2, essentially acting as an artificial lung, and then an extracorporeal pump returns this now oxygenated blood retrogradely into the systemic circulation via a large arterial outflow cannula, typically femoral artery. It offers the highest flow augmentation, anywhere from 3 up to 7 LPM, depending on the setup.
So critically, ECMO provides that oxygenation capability that none of the other NCS devices offer on their own.
Precisely. It's the only platform that can support both failing lungs and a failing heart simultaneously. But, similar to tandem heart, it requires very large access sites, typically 17 to 21 French in the vein and 14 to 19 French in the artery. The sheer size of these catheters really underpins the high rate of vascular complications associated with ECMO, especially limb ischemia.
Okay, so we have this spectrum of devices, from modest support with smaller access to massive support with very large access and higher inherent risk. That sets the stage perfectly for looking at the actual clinical trial evidence.
Right, and the inherent risk, especially with those large sheaths, means the benefit of using the device really needs to be proven by definitive clinical evidence. Unfortunately, that high-level randomized evidence has been, well, pretty sparse and, until very recently, quite frustratingly inconclusive.
Let's start with the first major RCT in this specific space, BCIS-1.
BCIS-1, published back in 2010, was the first big randomized trial to look specifically at using the IABP versus just standard care for high-risk PCI. The hope, the expectation, was that providing that IABP safety net would improve short-term outcomes.
But the headline result, the primary endpoint, was negative.
It was. At the 28-day primary endpoint mark, there was absolutely no significant reduction in MACE, major adverse cardiac and cerebrovascular events in the IABP group compared to the control group. The event rates were virtually identical, something like 15.2% versus 16.0%.
And worse, there was a safety cost.
There was. The IABP patients suffered significantly higher rates of access site complications and bleeding. So in the short term, the trial showed basically no benefit, only added risk.
But then came the twist, the long-term follow-up. This is where the story gets really complicated.
It does. The follow-up data, published later, looking out to 4.2 years, revealed a really astonishing and statistically significant result. The group originally randomized to IABP had significantly lower all-cause mortality. The hazard ratio was powerful 0.66.
Lower death rates years later, despite no benefit and more harm at 28 days. How does temporary support lead to a permanent survival gain like that, it seems? Counterintuitive.
It puzzled everyone, and still does to some extent. The leading theories revolve around the idea that maybe the IABP prevented episodes of prolonged myocardial stunning during the procedure, or perhaps it improved microvascular function in a way that allowed the heart muscle to recover more fully over the long term, leading to better preserved heart function years down the line.
But we don't know for sure.
We don't. The source is quite clear. That the BCIS-1 trial unfortunately lacked detailed cause of death data, which really limited the ability to pin down a definitive mechanistic explanation. So it remains this kind of mysterious win for IABP, but it certainly helps cement its role as the sort of default support device for many years.
Okay, that uncertainty sets the stage perfectly for the next pivotal head-to-head trial, PROTECT 2. Published in 2012. This one compared the newer, higher flow Impella 2.5 directly against the established IABP.
Right. PROTECT 2 was really intended to demonstrate the superiority of Impella's greater hemodynamic support. But history repeated itself in a way. It, too, failed to meet its primary endpoint. The trial was actually stopped early for futility.
No difference at 30 days again.
No significant difference in the composite major adverse events, or MAE, endpoint at 30 days. The rates were high in both groups, around 35% for Impella versus 40% for IABP, but not statistically different.
So 2 major trials, both failing their short-term goals.
Yeah.
But the source points out a really crucial procedural bias, a confounding factor in PROTECT-2 that made interpreting the result very difficult.
Yes, and this is perhaps the single most important lesson learned for designing future trials in this space. The Impella does provide superior hemodynamic support, and the operators in the trial clearly use that enhanced safety net. Even though the protocol recommended aiming for complete revascularization in all patients, the data showed that the Impella group received significantly more runs and longer durations of rotational atherectomy.
Ah, so the Impella wasn't necessarily failing to protect the patient better, it was actually enabling the operator to be more aggressive, to tackle harder, more calcified lesions they might have otherwise avoided if they only had IABP support.
Precisely. The Impella group was, in effect, undergoing a higher risk, more complex intervention from the start because the device allowed it.
So the study ended up comparing apples and oranges, almost. Like IABP plus complex but maybe incomplete revascularization versus Impella plus complex and more complete revascularization.
That's a very good way to put it. This disparity fundamentally compromised the standardization of the intervention being tested. It muddied the waters.
But the post hoc analysis, looking out a bit longer, provided a major clue, didn't it?
It did. When they looked specifically at the per-protocol population, those who strictly follow the trial rules, the Impella group actually showed a significant reduction in major adverse events at 90 days. It was about 40.0% versus 51.0% in the IABP group.
So a later benefit emerged.
Yes, and the source strongly suggests this means the original 30-day window was simply too short. It couldn't capture the clinical benefit derived from the more extensive, more complete revascularization that the superior hemodynamic support of Impella allowed. The survival benefit of getting a better, more complete fix only started to materialize after that initial acute post-procedure period had passed.
Okay, that makes sense. Now let's shift gears slightly to a more recent and arguably game-changing trial. Danger shock. Now, this wasn't in elective complex PCI. It was in patients with acute heart attacks complicated by cardiogenic shock.
Right, a much sicker, actively crashing population.
But it provided the first clear, meaningful RCT mortality benefit for Impella, didn't it?
It absolutely did. Danger shock compared the Impella CP against standard of care in about 360 patients who were in profound cardiogenic shock due to a large heart attack. The results were quite dramatic. They found a significant reduction in all-cause mortality at 6 months. For the Impella group, 45.8% death rate versus 58.8% in the standard care control arm. That 13 absolute percentage point difference is highly clinically significant and really confirmed the device's power in a true crisis situation.
That's a huge result. But we have to be cautious here, right?
Mm.
Can we really extrapolate that major mortality benefit seen in patients complex PCI patient? That feels like a pretty big clinical leap.
It is the central question facing the field right now. You're absolutely right. While the mechanism of action, the LV and loading is the same, the underlying disease process and the patient's stability are entirely different. However, the Danger Shock trial did provide another key lesson, perhaps just as important: the critical importance of standardized algorithms for device usage.
How they actually use the device mattered.
Immensely. Its success was attributed, at least in part, to mandating things like uninterrupted MCS for a minimum of 48 hours before even attempting to wean support. This shift away from just ad hoc operator intuition usage towards structured, protocolized deployment and weaning is a crucial takeaway for the design of future complex PCI trials as well. Standardization matters.
Okay, so given these mixed results from the early RCTs, it's understandable why the community leans so heavily on real-world data, RWD, to try and guide decisions, even acknowledging the inherent flaws in that type of data.
Exactly. When the RCTs are inconclusive, you look for signals elsewhere.
Before we dive into the main body of RWG mostly focused on Impella, let's quickly cover the observational findings for the other platforms, Tandem Heart and VA ECMO. What does the non-randomized data suggest there?
Sure. For Tandem Heart, the evidence base is really quite restricted, mostly small, single-arm case series. This reflects its lower adoption rate, likely due to that technical complexity of the transseptal puncture we mentioned. There was a meta-analysis that did try to compare it to Impella 2.5 using observational data. It found broadly comparable procedural outcomes overall. But interestingly, Tandem Heart showed slightly higher short-term mortality in that analysis, around 8% versus 3.5% for Impella. But it actually had lower rates of major bleeding, about 3.6% versus 7.1%.
Lower bleeding. That's likely due to the venous access site for that big inflow cannula, right?
Yeah.
Femoral vein access is generally less prone to catastrophic bleeding than large bore femoral artery access.
That's the most likely explanation.
But the potentially higher mortality might hint that the technical challenges of the transseptal approach itself could contribute to some acute instability or complications in some cases.
That's certainly the plausible trade-off suggested by that limited data. Now, turning to VA ECMO, which provides the highest level of support, the evidence there is also observational, but it reveals a really critical insight regarding the timing of initiation, the difference between prevention and rescue.
Ah, putting it in before the crash versus after.
Exactly. The data strongly suggests that prophylactic VA ECMO, meaning placing the support before the patient deteriorates significantly, maybe in anticipation of a very high-risk procedure, is associated with dramatically lower in-hospital mortality. One study showed something like 13.5% mortality compared to a staggering 77.8% mortality for rescue VA ECMO, placed only once the patient is already in profound shock.
Wow, a 64 percentage point difference. That hammers home the point. If you think the patient might need that level of support, you absolutely have to act preemptively, not reactively.
It's a critical principle across all MCS, but especially stark with ECMO. Although it's worth noting, some small comparative observational studies, like one with only 41 patients, did suggest potentially higher mortality overall with prophylactic VA ECMO, compared specifically to prophylactic Impella CP, maybe 14.3% as 7.4%. But the patient populations are likely very different, making direct comparison tricky.
Okay, so let's now examine the larger body of RWD from major registries, both in the US and Europe, which generally seems to paint a more optimistic picture about MCS, particularly Impella.
Yes, the RWD, for the most part, supports the underlying hypothesis of MCS quite robustly. For instance, the multicenter CVAD registry in the U.S., which focuses on Impella, showed pretty clearly that MCS successfully prevented episodes of profound periprocedural hypertension during complex PCI.
And the clinical effect of preventing that low blood pressure.
The key downstream effect they highlighted was lower rates of subsequent acute kidney injury and also measurable improvements in LVEF observed at 30 days post-procedure.
So that connects the dots nicely. Maintaining hemodynamic stability protects vital organs like the kidneys and seems to help the heart muscle itself recover faster.
That's the interpretation. And this idea of a preventative strategy is heavily favored by the RWD analysis. Multiple retrospective studies looking at large data sets from both Europe and the US consistently suggest that initiating Impella support prophylactically, the preventive approach, is associated with reduced in-hospital mortality and often reduced one-year mortality as well, compared to using it only in a reactive or bailout situation after the patient gets into trouble.
And this finding was persuasive enough to actually spur more research.
It was. It was a key driver behind the creation of the dedicated Protect EU registry, which is prospectively gathering real-world data specifically focused on the 90-day outcomes of preventive Impella use in Europe.
We also have some crucial comparative effectiveness data coming out of large national registries, trying to compare devices head-to-head using observational data. You mentioned the US NCDR CAF PCI registry analysis.
Yes, that was a significant piece of work. They looked at nearly 7,000 high-risk PCI patients recorded in the registry. The crucial part is they used propensity score analysis.
Ah, the statistical technique to try and level the playing field between groups in non-randomized data.
Exactly. Propensity scoring is a statistical method designed to estimate the causal effect of an intervention, like Impella versus IABP, by trying to account for that inherent selection bias. It statistically matches patients who received Impella with patients who received IABP based on dozens of similar baseline characteristics: age, comorbidities, LVEF, anatomy scores, etc., essentially trying to create pseudo-randomized groups after the fact.
So it's the best statistical attempt we have to adjust for the fact that in the real world, the patient who got Impella was probably sicker to begin with, or maybe had a more aggressive operator who chose Impella for a tougher case.
Correct. It tries to balance those measured confounders. And that large propensity score analysis found that Impella use was associated with a significantly lower rate of in-hospital MAC, major adverse cardiac events, compared to IABP use.
Even though the Impella patients likely had more complications.
Yes, that's the key finding. Despite the Impella group having more peri-procedural complications overall, particularly bleeding and vascular issues related to the larger access size, their rate of the composite MC outcome was lower. Again, it points to that trade-off. The higher level of support seemed to allow for a lower rate of major ischemic events, even if it came with a higher procedural risk cost.
The RWD also gives us that longer-term perspective that the original short-term RCTs lacked. Tell us about the PROTECT 3 registry.
PROTECT 3 was important. It was a prospective FDA-audited study, essentially a registry, that compared outcomes in over 1,100 contemporary high-risk PCI patients receiving Impella support against the historical control patients from the earlier PROTECT 2 randomized trial. This comparison allowed researchers to see how clinical practice and outcomes had evolved over time.
And what were the key differences they saw between the PROTECT 3 patient group and those older PROTECT 2 controls?
Well, fundamentally, the PROTECT 3 cohort, the more contemporary group, was undergoing PCI on more difficult anatomy, more complex lesions, more calcified vessels, generally higher risk vessels according to scoring systems. The overall case complexity had clearly increased over the years.
But despite tackling harder cases,
Despite that, the operators in PROTECT 3 actually achieved a greater degree of complete revascularization compared to the historical group. They were fixing more of the blockages.
so complexity went up, but the completeness of the fix also went up. How did the actual patient outcomes look at 90 days?
The outcomes were significantly better in the contemporary PROTECT 3 group. They showed significantly lower adjusted MCCE rates, down to 15.1% compared to 21.9% in the PROTECT 2 controls. That's a substantial drop.
And the safety profile, did that improve too?
That was perhaps the most stunning finding. There was a massive improvement in safety, specifically decreased in hospital major bleeding. It plummeted from 9.3% in the PROTECT 2 historical controls down to just 1.8% in the PROTECT 3 registry patients.
Wow, from nearly 1 in 10 patients having major bleeding down to less than 2 in 100. That's a huge reduction. What does that signal?
It strongly suggests significant strides in several areas simultaneously. Probably better operator technique and experience with large bore access, maybe more careful patient selection, and almost certainly improvements in vascular closure techniques and post-procedural management.
It shows the learning curve in action.
Absolutely. It confirms that as operators gain experience and hospital protocols become more standardized, using these high-flow devices for complex PCI can become far safer, while still enabling that more complete revascularization needed for good long-term outcomes. The technology, combined with learned technique, seems to be working better over time.
Okay, despite all these really powerful, generally optimistic findings from the RWD, we absolutely need to apply that critical lens. What is the major unavoidable limitation that prevents RWD, even with propensity scoring, from completely replacing the need for definitive RCTs?
The fundamental limitation, the major threat that always looms over RWD, even after sophisticated techniques like propensity scoring, remains treatment selection bias. RWD just struggles to capture all the critical unmeasured variables, things like the subtle nuances of operator skill and judgment, specific hospital protocols for patient management, or fine-grained patient characteristics like frailty that might dictate who gets offered prophylactic support in the first place.
So patients who receive prophylactic MCS are just inherently different in ways we can't always measure from patients who don't.
Fundamentally different, yes. You can statistically adjust the data for the differences you can measure, but you can never be entirely sure you've accounted for everything. You can never achieve the pure, unbiased causal interpretability that comes from true randomization.
And there was an FDA collaboration study that really highlighted this analytical challenge, didn't it?
Yes, that study was quite sobering. It specifically looked at comparing outcomes between IABP, Impella, and unsupported PCI in the context of acute myocardial infarction with cardiogenic shock, AMICS. Their main conclusion was that these kinds of observational comparisons are frequently challenged by violations of the underlying statistical assumptions needed for causal inference. They confirmed that while RWD is incredibly valuable for generating hypotheses, tracking real-world trends, and identifying potential safety signals, it often falls short when trying to definitively prove causation.
So RWD can show us what is happening, but not always definitively why.
Precisely. Only rigorous, well-conducted randomized data can truly confirm whether the device itself is improving outcomes or whether the improved outcomes we see in RWD are simply due to selecting healthier or different types of patients for the more aggressive intervention pathway.
Okay, that's a crucial caution. Let's pivot now to addressing the immediate physical drawback of these higher flow devices. That large bore access problem. This seems to be the main driver behind the bleeding and vascular complications that remain the biggest risk factor.
It absolutely is the central engineering and procedural challenge. Current high-support MCS devices like Impella CP or ECMO cannulas require sheaths ranging from 13 French all the way up to 23 French.
And just for perspective, a standard diagnostic heart catheter is maybe 5 or 6 French.
Exactly. So creating a hole that large in a major artery, usually the femoral artery, and then needing to maintain the patient on therapeutic anticoagulation, it just introduces significant inherent risks.
Hmm.
Vascular dissection, perforation, vessel rupture, limb ischemia if the sheath obstructs flow, pseudoaneurysms, and major, sometimes life-threatening bleeding.
So if you can't easily make the device itself smaller, at least not yet, how are clinicians actively working to mitigate these really significant access-related risks today?
Well, mitigation has become an entire subspecialty within complex PCI. It really starts with meticulous planning before the procedure even begins. Pre-procedural imaging, whether it's a CT angiogram of the pelvis and legs or detailed ultrasound, is becoming essential. You need to precisely map out the peripheral vessel anatomy, measure the artery's true caliber, and identify any significant plaque, tortuosity, or calcification before you attempt to insert a 14 or 17 French sheath. You have to know exactly what you're getting into.
Forewarned is forearmed. And then after the procedure, safely removing that large sheath relies heavily on vascular closure devices, VCDs, right?
Absolutely. The VCD technology has evolved significantly to try and cope with these larger holes. The most common approach involves suture-based systems, like the Perclose ProGlide device. A key technique here is called pre-closure, placing the sutures before inserting the large MCS sheath, leaving them untied, and then tightening them down immediately after the sheath is extracted to close the hole.
But what if the MCS device needs to stay in for hours or even days, like in shock or for prolonged recovery?
That's a major challenge. Maintaining the sterility of those pre-placed sutures when a device is indwelling for a prolonged period is logistically difficult and increases infection risk.
Which leads to alternative or hybrid closure methods.
Exactly. Sometimes hybrid methods are used, combining maybe a suture-based system with a plug-based system. There are newer plug-based devices, like the Manta VCD, specifically designed for large bore closure, accommodating sheaths up to 23 French. These are deployed after the sheath is removed. And for the absolute highest risk removals, operators often employ a clever safety technique involving a crossover balloon.
Okay, explain the crossover balloon. What does that involve?
So in cases where the access artery is known to be fragile, heavily calcified, or just looks worrisome, the operator will gain access to the opposite femoral artery, the contralateral side. They advance a separate balloon catheter up and over the aortic bifurcation, positioning it in the iliac artery just above the large sheath insertion site. Then, just as the large MCS sheath is being pulled out, they inflate this crossover balloon.
Temporarily blocking flow from above.
Exactly. It temporarily occludes inflow into the iliac artery, giving them immediate proximal control over any potential catastrophic bleeding, while the primary closure device, suture or plug, is being deployed and achieving hemostasis. It's an essential safety margin for the trickiest removals.
Makes sense. Now, since femoral access remains the most common but also the most challenging site, the field has actively developed alternative access strategies, which the source outlines.
Yes, we're seeing 3 primary alternative approaches gaining traction, designed to either bypass problematic femoral arteries or modify the femoral approach itself.
First, transaxillary access, using the artery in the shoulder area.
Correct. This involves placing the support catheter, usually an Impella, through the left axillary artery. The major potential benefit for the patient is early mobility. They aren't necessarily confined to strict flat bed rest like with femoral access. Manual compression for hemostasis is also possible if needed, and significant obstructive atherosclerosis is actually less common in the axillary artery compared to the femoral.
What are the downsides?
The main drawbacks are typically a smaller vessel caliber compared to the femoral, a slightly increased theoretical risk of stroke due to the closer proximity to the cerebral circulation, though this is debated, and the anatomy is just more challenging. You absolutely need careful pre-procedural imaging, like a CTA or ultrasound, to avoid damaging the brachial plexus nerves or surrounding veins during access and closure.
Okay. Next, the really technically advanced one, transcaval access.
Yeah, this technique is conceptually brilliant, but definitely complex. It's designed to entirely bypass diseased or small iliofemoral arteries. The mechanism involves intentionally creating a temporary controlled channel between the inferior vena cava, the large vein returning blood to the heart, and the adjacent abdominal aorta, usually below the kidneys. This is done using specialized catheters and electrified guide wires under imaging guidance to cross between the two vessels. The MCS device is then inserted through this temporary tunnel.
That sounds like creating controlled trauma. What are the benefits that would justify that level of complexity?
The potential benefits are quite compelling in the right patient. Access site bleeding is rare because the puncture site is deep inside the abdomen, not in the groin crease. And there's essentially no risk of causing limb ischemia because you haven't instrumented the leg arteries.
But the risks must be significant too.
They are. Retroperitoneal bleeding into the space behind the abdominal cavity is a major concern because you obviously can't apply manual pressure back there. Closure of the aortic and IVC puncture sites after device removal is also complex, requiring specialized nitinol occluder devices similar to those used for closing holes in the heart. And there's a risk of accidentally creating a persistent high-output fistula, an abnormal connection between the aorta and IVC if the closure isn't perfect.
Right. And the third strategy you mentioned is the Shipp's technique. This sounds more like a refinement of the standard femoral approach.
It is. The SHIP technique, which stands for Single Access for High-Risk PCI, is really just pragmatic ingenuity. It's designed to reduce the number of arterial punctures you make in the patient. The operator inserts the large, say, 14 French impella sheath first, as usual. Then, instead of making a separate puncture for the PCI guiding catheter, they carefully pierce the hemostasis valve of the already placed large impella sheath with a micropuncture needle. Through that needle, they insert a separate, smaller, maybe 8 French sheath directly into the impella sheath, allowing them to perform the PCI concurrently through that second inner sheath.
So one large hole in the artery rather than one large hole and one medium-sized hole nearby.
Precisely. You minimize the total arterial violation. And interestingly, a potential benefit is that after the PCI is finished and that inner 8 French sheath is removed, the small puncture defect in the impella sheath's hemostasis valve often seals itself automatically, allowing the main impella sheath to remain safely in place if needed for ongoing support.
Very clever. Okay, this discussion about mitigating access issues brings us neatly to the future, where engineering is actively trying to solve this large bore problem directly, these novel MCS solutions based on expandable pump designs.
So this is arguably the most exciting area of development right now. The core innovation here is creating pumps that can be compressed into much lower profile sheaths, typically 9 or 10 French for insertion and removal. This drastically reduces the risk of vascular trauma. But once they're deployed inside the heart or aorta, they expand mechanically to achieve a much larger effective diameter, allowing them to deliver powerful hemodynamic support, often comparable to or even exceeding current devices, potentially reaching 5 to 8 liters per minute of flow.
A smaller hole going in, but big support once it's in place. That's the holy grail. Let's detail the 4 key novel devices mentioned in the source, starting with the one that seems furthest along in development. Impella ECP, expandable cardiac power.
Right. The Impella ECP is designed with an insertion and removal profile of only 9 French. That's barely larger than a standard 8 French PCI guiding catheter. It's a huge step down. Once deployed across the aortic valve, it expands to an effective profile of 18 French, allowing it to deliver flow rates between 3.5 and 5 LPM, similar to the current Impella CP or even higher.
And it has some unique features.
It does. Reportedly, it can cross the aortic valve without needing a guide wire, which could simplify the insertion process. And the cannula itself is designed to collapse down when the pump motor is inactive, which might minimize interference with the native aortic valve leaflets during support.
A 9 French entry profile really is potentially revolutionary, especially for prophylactic use. It dramatically lowers that risk threshold for deciding to offer the device in the first place.
It fundamentally changes the risk-benefit calculation, absolutely. And it potentially makes the safety data being gathered in the current large RCTs, which use the 14 French devices, almost immediately obsolete if ECP proves safe and effective.
Okay, next up, Elevate, from a company called Magenta Medical.
Elevate is another expandable pump technology. It uses a 10 French insertion profile, so slightly larger than ECP, but it expands dramatically to an effective profile of 30 French once in place. This large expansion allows it to achieve very high levels of flow, reportedly in the 5 to 8 LPM range. A unique feature highlighted is its ability to provide direct aortic pressure measurement from the device itself, offering potentially more accurate, real-time hemodynamic feedback compared to just peripheral blood pressure cuffs.
And the Supera system.
Supera, from Supera Medical, also utilizes a 10 French insertion profile. It expands to an effective profile of 22 French and promises flow rates greater than 5.5 LPM. Similar to Elevate, it features integrated aortic and ventricular pressure sensors for real-time direct pressure monitoring. It also incorporates a highly flexible catheter design, which they suggest is intended to minimize contact with the ventricular wall and potentially reduce the risk of arrhythmias caused by catheter irritation.
And finally, the source mentions the Vitalist platform from Boston Scientific.
Yes, Vitalist represents Boston Scientific's entry into this next-generation MCS space with their continuous flow pump design. They recently completed their first in-human feasibility study. Effectiveness data comparing it to others isn't available yet, but its inclusion signals that all the major players are recognizing the trend.
So the clear industry direction is towards low-profile entry combined with high-flow support capability. This really promises to address, maybe even solve, that fundamental access injury paradox that has plagued the field and limited MCS adoption for the past decade.
That's the hope, and the engineering is certainly impressive.
Okay, so despite this promising RWD and the excitement over these new 9 and 10 French devices, we still desperately need that definitive randomized evidence to resolve the clinical uncertainty left over from BCIS-1 and PROTECT 2. Right. RWD shows association. Only RCTs can really prove causation.
Absolutely. We need that level 1 evidence. And thankfully, 2 highly anticipated large-scale randomized trials, PROTECT 4 in the U.S. and CHIP BCIS-3 in the U.K., are currently underway and expected to deliver those crucial results sometime around 2026.
Let's look closely at how their designs have evolved. How have they tried to learn from the frustrating lessons of those earlier inconclusive trials?
PROTECT 4 is the larger of the 2, aiming to recruit 1,252 patients across the U.S. It's comparing Impella-supported complex PCI directly against standard of care PCI, which might include discretionary IABP use. Just-shunt BCIS-3 is a bit smaller, aiming for 250 patients in the UK, comparing MCS, primarily Impella, against standard of care PCI, but with stricter limits on control group support.
Okay, the first major improvement seems to address that issue from PROTECT 2, where the control group had to get an IABP, which complicated things.
Right, because IABP is still a form of MCS, even if less potent. The new trials handle this better, offering more flexibility. PROTECT 4 leaves the decision to use IABP in the control arm up to the operator's clinical discretion, reflecting real-world practice more closely. CHIP BCIS-3 goes even further. It explicitly limits the use of IABP or ECMO in its control arm only to confirmed bailout situations, meaning the patient is actively crashing. This makes the control arm a much purer representation of contemporary, unsupported standard of care PCI.
That seems like a cleaner comparison. What about the patient inclusion criteria? Have they refined who gets into these trials?
Yes, significantly. They've learned to kind of uncouple LVEF and coronary anatomy, treating them more as independent factors that contribute to overall risk, rather than requiring both to be severely abnormal. And critically, they specifically mandate the inclusion of patients with high-risk anatomical features, things like proximal LAD lesions, complex bifurcations, heavily calcified lesions, or CTOs, rather than just using broad categories like 3-vessel disease. This ensures they are really studying the population most likely to benefit from the enabling effect of MCS during a difficult procedure.
And importantly, they are now including patients presenting with acute coronary syndromes, which PROTECT to explicitly exclude, right?
Yes, this is a major shift. Both PROTECT 4 and CHIP BCS-3 are including patients presenting with NSTEMI and even recent STEMI after initial stabilization. This acknowledges the growing realization, especially post-danger shock, that these acute patients, even if not in full shock, often have very poor hemodynamic reserve. They represent a subgroup where elective MCS might provide the most significant stabilization benefit, potentially leading to safer and more complete revascularization.
And perhaps the most crucial lesson learned: the primary endpoint timing. They recognized that 30 days was just too short after PROTECT 2's post-hoc analysis.
Absolutely. The time horizon for the primary endpoint has been radically extended in both trials. CHIP BCIS-3 is looking out to 1 year for its primary outcome. PROTECT 4 is extending follow-up all the way out to 3 years.
3 years?
Yes. This explicitly acknowledges the lesson that the real clinical benefit of enabling a more complete and complex revascularization procedure might take months or even years to fully manifest in terms of reduced mortality and repeat events. It's not just about getting through the procedure safely in the first 30 days.
And they simplified the endpoint itself.
They did. They moved to a more standard composite endpoint, typically including death, myocardial infarction, MI, stroke, unplanned revascularization, or cardiovascular hospitalizations.
Okay, these study designs definitely sound more robust, more thoughtful, based on past experiences. But even with these massive improvements, the source suggests there are still some key questions or limitations that will likely remain even when the results land in 2026.
That's right. Despite the progress, there are still significant lingering concerns, mainly around standardization and how safety is evaluated, that these trials don't seem to fully address.
First, that issue of procedural standardization. The atherectomy imbalance that skewed PROTECT 2. Have the new trials fixed that?
It's not entirely clear that they have, unfortunately. Neither the Protect 4 nor the CHIP PCIS 3 protocols, as far as published details go, specify exactly how they will standardize the actual PCI procedure itself to prevent unbalanced use of advanced aggressive tools like rotational or orbital atherectomy between the MCS-supported arm and the control arm.
So we could run into the same problem again. If the Impella group consistently gets a technically better or more complete revascularization simply because the device allows the operator to push the limits on calcified lesions, the trial might show a positive outcome for Impella.
But we still wouldn't know for sure if that positive outcome is due to the direct protective effect of the MCS itself during the procedure, or if it's simply due to the superior revascularization that the device enabled the operator to achieve.
It potentially repeats that same confounding vulnerability from PROTECT 2.
It does seem that way. The second major limitation highlighted relates to how safety events are handled in the primary analysis. Key safety outcomes, specifically major bleeding and vascular complications, the main downsides of current MCS are notably not included as components of the primary efficacy endpoints in these trials.
Really? That seems like a huge oversight, given that vascular injury and bleeding are the #1 reasons clinicians hesitate to use these devices prophylactically.
It's likely a deliberate choice to keep the primary endpoint focused purely on efficacy, on preventing ischemic events and death. Protect 4 does mandate pre-procedural vessel imaging and encourages best practices to mitigate vascular risk, which is good. But the ultimate success or failure of the trial, based on hitting its primary composite endpoint, won't directly hinge on whether the complication rates were acceptable or not. That will be a secondary analysis.
So the trials might show benefit on the primary endpoint, but won't give us the definitive final word on the true safety profile in isolation.
Not as part of the primary conclusion, no. The third limitation is simply the unfortunate reality of trial timelines, that evidence lag again.
They were designed and launched before these newer low-profile devices really hit the scene.
Exactly. These large, expensive, multi-year trials were conceived and initiated before the novel 9 and 10 French expandable devices we just discussed, like Impella ECP, Elevate, Supera, were even close to market availability. Therefore, the safety data collected in Protect 4 and CHIP BCIs 3 will inevitably reflect the use of the older, larger bore 14 French Impella CP technology. If those newer low-profile devices genuinely prove to drastically reduce vascular complications in subsequent studies,
then the safety data from Protect 4 and CHIP BCIs 3 might already be outdated, not reflecting contemporary best practice by the time it's published.
that's the risk. And finally, there's that one nagging technical detail that always matters hugely in cardiology trials. How exactly do you define a paraprocedural heart attack, an MI?
The troponin cutoffs.
Precisely. The trial protocols don't appear to specify crystal clear, standardized troponin cutoffs that will be used across all sites to define a periprocedural MI. Slight variations in how this is defined can significantly affect the reported rates of this key endpoint component. It could potentially make comparing the results directly between Protect 4 and CHIP BCIs 3 a little more difficult, even if they both ultimately conclude that the device strategy is beneficial overall.
Okay, lots to look forward to, but still some important caveats to keep in mind when those results arrive. So let's try to synthesize everything we discussed. We have the situation where the rapid adoption of powerful MCS devices has been driven largely by, well, strong clinical intuition. The undeniable fact that these devices do provide superior hemodynamic support and this large body of generally supportive but methodologically limited real-world data. We're still awaiting that definitive level 1 RCT evidence from Protect 4 and CHIP BCIs 3, but the clinician on the front lines in the cath lab today faces the immediate practical task of deciding when to offer preemptive MCS now.
That's the reality. And the current consensus, while we wait for those definitive trial results, seems to suggest that clinicians should actively consider prophylactic MCS when there is a strong clinical concern for potential hemodynamic compromise during the planned PCI. This decision usually involves blending the assessment of patient risk factors, like low LVEF, frailty, comorbidities, with the anticipated anatomical complexity of the procedure, left main, CTO, heavy calcium requiring atherectomy.
And people are trying to create algorithms or scores to make this decision more objective.
Yes, to standardize this complex decision-making, many institutions and expert groups are proposing various algorithms or scoring systems. These try to integrate specific patient substrate factors and coronary anatomy requirements to predict the need for MCS.
But you mentioned earlier that these scores can be highly variable.
They are, definitely. Different algorithms assign different weights to various risk factors based on severity and combination. It often still comes down to the individual heart team's experience and judgment in interpreting those scores for a specific patient. However, there is one practical dynamic tool that experts increasingly recommend using, especially in cases where there's uncertainty or hemodynamic equipoise.
What tool is that?
It's using pulmonary artery catheter, PAC evaluation, like a Swan-Ganz catheter. This allows the team to get real-time invasive hemodynamic measurements before and during the procedure. It really helps identify those patients who already have elevated cardiac filling pressures, like a high wedge pressure,
Yeah.
and poor cardiac power output at baseline. Those are the ones who are most likely to truly need and benefit from upfront circulatory support.
And it allows for monitoring during the case, too.
Critically, yes. For patients who look okay initially, the PATE allows for continuous dynamic monitoring throughout the procedure. If their hemodynamics start to decline significantly mid-case, the operator sees it immediately and can make the decision to initiate support preventatively at that point, rather than waiting for a full crash, avoiding that reactive bailout approach.
And we know from the ECMO data and common sense that avoiding the bailout scenario is crucial because it's associated with dramatically higher mortality.
Absolutely. That dynamic monitoring and willingness to act preemptively based on deteriorating hemodynamics is key. The need for continuous learning, adaptation, and refinement of protocols in this field is just paramount. As we look forward to this next crucial wave of randomized trials, the entire scientific community needs to keep collaborating, always recognizing that both observational studies and even the most rigorous randomized trials carry their own inherent biases and limitations. A deep understanding of the analytical methods being used, awareness of the rapidly evolving technology, and just nuanced clinical decision-making based on the totality of evidence are all going to be necessary to keep improving outcomes for this incredibly challenging patient population.
It really sounds like a field where the technology is almost outpacing the evidence base, and where the ultimate success of even the best device often depends just as much on the precise technique, the timing, and the judgment of the human operator using it.
That captures it very well. It requires continuous critical engagement from everyone involved.
That brings us to the close of this deep dive into the complex and evolving world of mechanical circulatory support for high-risk PCI. Thank you for watching The Funnel Effect.